And I'll give you an example. Ngilu wanted to start social health insurance. Went to President Kibaki. Kibaki said no. Why? The 6 pillars were not aligned.
So I'll ask you, when you interact, because as you do your stories, and you take an investigative approach, that's one. But as you do your stories, you interact with people who are in dire need, right? What would be 2 things that come across to you as need to be priorities? Yeah,
we are human beings. You are dealing with a human being. I can take you to a hospital, a level 4 hospital, where disabled women give birth on floors.
Hello, welcome to the One Health Lens podcast, where we have conversations around health and related topics, making them simple and easy for you to understand. Guess what? It's a new season! I'm your host, Dr. Diana Wangari Gitao.
And I am your co-host, Dr. Simon Moshara Kigondu, and today I also am part of the guest list.
The guest list, huh? I mean, a lot has been happening, so I even have a new co-host, Leon. You must come more to season 3 of the podcast, yeah? Mm-hmm. I mean, we're starting off on a high note to understand what's the state of, as they call it, healthcare, right? And today I'm doing more of listening because, Leon, you've been on the ground, as they call it, yeah? You've had interactions, both good and bad, from a patient, provider to government, you know? And I wanted to just hear from you. What has been happening this past quarter? We're in March, right? Mm-hmm. What's been happening? What have been the big stories in this past quarter?
First, we have to consider the fact that USAID is dead and gone, thanks to US President Donald Trump. Some people feel that he should have told us that I will shut it down in 6 months to give us ample time to prepare. But my question is, where have we been all these decades USAID has been around? We're supposed to be having our own resilient and reliant healthcare systems. So it's time we are being compelled to carry our own cross. So for me, it's a blessing and it's also a curse in the sense that patients out there are really suffering. Last week we saw the health CS flag off a consignment of ARVs. And whenever you see a government person, this is what this job has taught me. Flag off a consignment, no, things are very bad. That is the truth. And what I noticed is that no one is talking about line 2 ARVs. Remember, Kenya consumes 435 packets of line 1 ARVs per month. Kenya consumes 101,000 line 2 ARVs per month. In our co-financing deal with Global Fund is supposed to deliver 3 million packets. PEPFAR is supposed to deliver 2.85 million packets, which means in a single financial year, we are supposed to be consuming 6 million packets. So when you see the CS flag of prophylaxis combined with line 1, at 2 million and says it will last us for 2 years, she's not being honest. And to me, that shows how serious the problems we are dealing with. There's also SHIF. The reality is we are not doing well. Majority of the Kenyans cannot be spending out of pocket, yet we have an insurance healthcare system that is supposed to take care of them. So 2 weeks ago, I did a story. We need to talk about the secret escrow accounts that the government has and where they are being held by Safaricom, Apayro, and Convergence Limited. So basically, Diana, this is what happens. When you contribute to SHIF, all your money in the next 24 hours, every evening, it goes to a secret escrow account, which The former Attorney General told me he warned the government about that arrangement. He said it is an illegality and goes against the Public Finance Act. And no one wants to tell us what they are doing with that money, because from what I've seen in the contracts the Ministry of Health and Safaricom and partners signed, they were supposed to start getting back all the money they had invested in the IHTS system from February this year. Now, when February hit, it means all the contributions are first supposed to be going there for the people who invested to get their money. That explains the shortage. That explains why we cannot be able to sort out medical claims, as Rufa has been telling us number times and again. That is why foreign hospitals, there are Kenyans who are stranded in India because no one out there can take a GOP from government and the Ministry of Health seriously. They have debts upon debts translating into billions, and Kenyans continue to suffer. That is the sad state of the situation, just in a nutshell.
Immediately I want to ask, is there any good? Is there any good?
Any good, I would say, when we look, doctors have been trying. And for me, the good aspect is that we have doctors who, despite all these hurdles, they show up to work. So for me, I would give them an A for that, for just showing up. Because as much as there are challenges, even medics themselves are facing challenges, no salaries, interns, and all that, they still do the most humane thing, which is to show up and save a life. So for me, from where I sit, that's the only good thing.
I mean, and I agree with you. It's also voices. I feel like more people are now speaking up. Even patients are speaking up. People are being bold and saying, this is why I am, these are my struggles, and they're showing up. Kigondo, President of Kenya Medical Association, all these meetings you go to that you never invite me. Past quarter, 2025, what's been happening? Top 3 things.
Yeah, the Kenya Medical Association has been very active in the health sector space. And April 14th to April 17th, we are having our annual scientific congress and in Kisii. And the way we framed it is that this time, immediately after the conference, we will have policy declarations that the Ministry of Health must adopt to improve healthcare in this country. And therefore, we invite everyone to that particular meeting. But if you forget anything else in this podcast today, do not forget that the government, through Treasury, is the biggest culprit in the slogan of SHA is not working. You've heard that SHA is not working. And for sure, SHA is not working. And why? The Treasury was supposed to allocate 50 billion to the primary healthcare fund. It allocated 6 billion. Treasury was supposed to allocate 75 billion shillings to the Emergency and Chronic Care Fund in the new act. It allocated 4 billion. So, what was their plan? Their plan was to get money from SHIF. SHIF deducts, it's ideally supposed to deduct 2.75% of earnings, but who are suffering? Salaried people, because they are the only ones you can get. And I can assure you, you will not be able to get those people who they claim they can do means testing. So you have a very, very annoyed salaried audience who are, by the way, they are being ripped off, literally. I can give you my example. My shift deductions increased tenfold, yet the services went to zero. So, if you forget anything else, why SHA is not working is because the government and by extension Parliament through Treasury have not allocated what they are supposed to allocate to the fund. Therefore, you may kill the boss of Shah, Abdi, but the problem is Treasury and Ministry of Treasury, which doesn't give money to the Ministry of Health, and Parliament, which has allocated more money to themselves and reduced allocations to healthcare.
I mean, you sit on this meeting, some of this stakeholder meetings, right? I would imagine you put them to task, right? What's the feedback you get? What's the response? We're working on it. 3 months later, 6 months later, they're still working on it. What's the response? Because there's no I'll come and ask Leon today, where's my pencil, right? He says, I'll bring you. Then tomorrow, pencil. I can't keep repeating that. What happens? It's been months.
Yeah, so I think going forward, when we are coming towards the election of 2027, when
we're in 2025.
yeah, we have 2 years. By the way, we are patient. There is no problem. We are going to replace people. What we will do is to separate Treasury from the Ministry of Finance. And once you do that, then you do not have control, for instance, of the executive of Treasury, so that we start prioritizing things that are important, like health. It is not that there is no money. It is that money is just not prioritized for healthcare. Health is a shared function. You have county and you have the national government. The money we are talking about, for instance, the one to Social Health Authority, comes from the national budget. There is also county money for health. And as you know, the national government takes the bigger cake instead of allocating monies to the county governments, which would then be channeled to healthcare, as it were. So what we did, and we as Kenya Medical Association have given a lot of memorandum to this whole operationalization issue. It's a good thing, the concept, but it's way before time. And I'll give you an example. Ngilu wanted to start social health insurance. Went to President Kibaki. Kibaki said no. Why? The 6 pillars were not aligned. The first one is governance. The policies were not in place. So what did they do? They did a good policy, National Health Sector Strategic Plan 2. 2, the facilities on the ground were not, they were in shambles. So what did they do? They did a policy of improving them. And facilities were improved with the help of Ministry of Health, KMPDC, and the provincial government. 3, there was no money. Health was a dependent sector. So what did they do? They made it so efficient that by the time the governors came in 2013, health was giving money to the national treasury. And there were no supplies. So what did they do? They ensured that FIF is working. It got improved over time. And service delivery improved dramatically. And hence, when the governors came in 2013, they found very rich hospitals. And that is what is called putting the cart before the horse in this Shah-Shi thing. You launch a system without all the components being ready. I think you're setting yourself up for failure.
I mean, Leon, when you... I'll tell you my perspective. I always get skeptical around these conversations around we'll put a policy in place, we'll put this, right? Because it always comes back down to, if I'm sick, anyone is sick, I want service when I need it without having to even just call someone to help me with money. Forget even fundraising on a large scale, just call. So I'll ask you, when you interact, because as you do your stories, and you take an investigative approach, that's one. But as you do your stories, you interact with people who are in dire need, right? What what would be two things that come across to you as need to be priorities? Yeah. And maybe it's not a fair question. It's not a fair question, actually, right? But then what would you say are the common things you hear, right? When you interact with patients, it could just be the mwananchi, as you say. What are the things? Let's forget the policy. Let's forget this big talk. What are they saying?
Number one, very simple 2 words, medical touch. And this is what I mean. We are human beings. You are dealing with a human being. I can take you to a hospital, a level 4 hospital, where disabled women give birth on floors in this day and age. I can take you to that same hospital where you find nurses are too strict. They even use very insulting words. Yeah? I can show you young girls who opt for the traditional birth attendants because of our poor, I call them our poor manners and medical touch. Just last week, I had to go to Kikuyu, follow up on a patient who doctors had left with the tubes for over a month. Since December 31st, no one has even reviewed that patient after the surgery. And that was a cardiac arrest patient. Can't sit, can't stand, can't walk, can't eat, just laying there. Did I have to do a story for the hospital to come and take their patients for a review? These little things are the ones that cost us. When you go across to the Ministry of Health offices, for example, health officials will portray the same character, the same dismissive. Kenyans are human beings. They are paying for services. In fact, you go to a health, people are more interested kama umelipa than where you are suffering from. And that's where the rain starts beating us. I've heard Dr. Kigondu talking about policy. We have the best policies. I can tell you, 2 weeks ago I was in Rwanda, Kigali, to pick another word. Anyway, I remember there was a presentation at AHIC from Malawi about community health workers. And when they were asked where they got all the wisdom, because Malawi is the only country in Africa that actually has community health workers on permanent and pensionable terms. And when they were asked where they got all these beautiful designs, the policies, guess what? They got it from the Kenyan Ministry of Health website. Rwanda itself will tell you most of our stuff, we're actually getting it. Why can't Kenya implement this beautiful policy they keep on putting in documents and launching left, right, and submitting reports? When are we going to start working what we are talking about every day? He has also talked about treasury, for example, which was another point I wanted to raise, because just last week, governors, senators, the health CS were in a meeting at Serena discussing about the USAID shutdown and where the country is going next. Guess what? Treasury was a no-show at that meeting. What does that tell you? You see, that's where most of our problem starts coming from. Number 3, when he was talking about the funds that we need to activate, someone sat somewhere and decided HIV, tuberculosis, and malaria to be under the pandemic fund and not under the chronic illnesses. Therefore, Kenyans cannot get these services. They have to pay out of pocket. SHA does not cover them.
True.
That was very intentional. And they knew what they were doing, because they want to take your money, but they don't want to spend it on you. The question is why?
Yeah. I think, and going back now to the point we really wanted to make. Does SHA work? You know, this question of SHA working or not. I think now we need to start looking at it from the patient point of view. What is universal health coverage? Universal health coverage is, according to the client, the patient, you have a problem, a health problem. You go to a health facility. You meet qualified healthcare professionals. You get quality diagnostics and you get treated. And you walk out without undergoing financial hardship. That's all. So the question for anyone who wants to measure, does SHA work or does SHA not work? When you are in need, was there a facility nearby that could actually solve your problem? And when you went there, you found people who are able to treat you, and you found diagnostics, and by the time you came out there, you came out with medication, and when you went home after some days, you were better, and you did not have to sell land for that particular service. That's where we need to come from. And of course, we have centered our discussion around healthcare financing. And for sure, because even as they launched this project, we, as the association actually said, health should be a tax-funded, public-driven thing. But what do they do? The problem with the Kenya Kwanza government is looking at the salaried worker as the source of everything. They do not have imagination to think that you as a government should provide a good environment for people to produce, to be able to build an economy. They kill the economy. They kill the economy. How? They just look at the salary. Oh, you have so much salary, let's tax you. Chief, we make a proposal. Cap. Because, okay, maybe some contributory may be necessary for now, before eventually is full guarded, they refuse. So someone increases my tax burden 10 times. They bring another useless tax called a housing tax, which will never benefit from. Yeah, it's a bad policy. It's just a bad Kenya Kwanza policy. Let's talk it as it is.
I agree with you.
Reducing your pay slip. They have reduced my pay slip ever since this government came into session. My pay slip has reduced dramatically. What else do? They allow banks to tax you interest rates for facilities you already had, and therefore they are reducing power. So me, who has to pay for my brother, for my parents, with a reduced pay slip, already I can't even afford my own health because that is already. So that's a governance issue. So there's a poor governance in this governance.
In this government.
Poor, terrible. So my parents, who used to go to a level 5 facility for their chronic medication, hypertension and all, they pass a policy that says you cannot get this medicine from a level 5. Where they live, there is no level 3, 4 with the medication and quality. So what happens? I buy the medicine again. So for 2 years again, they have not only reduced my my amounts using allowing banks to double their interest rates. They have useless housing levy fund, which has reduced my pay slip. They have quadruple 10 times SHA. Therefore, at the end of the day, the salaried worker has a net lower pay. The government has not improved the environment for you to increase. And then finally, where we work as health workers, they have not paid 31 billion shillings. Then you have a PS who has the audacity to threaten people. You owe them and you threaten them that you will deregister them, but you have not paid them. So I think as we continue doing this, that's SHA work. The patient, when they go to hospital, I had my brother who needed some surgery. He went to hospital and he was told this surgery is not listed in the gazetted things. Therefore, we don't pay for you. But because it was an emergency, we as a family had to raise 200,000 as a harambe and for him to undergo surgery. So does that mean I've increased my out-of-pocket allowance for a promise they say that this will reduce? So does SHA work? No, SHA does not work. It is increasing is reducing our pay. They are getting money. We don't even know escrow account where it is going, and so there's a problem at governance level.
I agree, and maybe this will be the final question to you, Leon, right? Because you go behind the scenes, right? And you have calls with government officials, people at senior levels across the healthcare spectrum, right? Be it providers, be it even research institutions, development partners, you know. And you know, one thing we forgot to mention, USAID wasn't just a factor of, the impact isn't just the programs, it's even all the workers who are laid off, you know, mental health challenges. We've had conversation with people who are saying, I don't know what next, you know. But my final question to you is, it seems it's as Kigondo said, it's a governance issue, right? What's your sense when you have this conversation? Is it that people just don't care? Is it a factor of they feel they're untouched? Is it a combination? What's the issue? Because it can't be that things are this bad, yet...
I will go back to what I said earlier, human touch. The PS, Kim Tai, is speaking to doctors like that threatening to shut down hospitals because he lacks that human touch to know these are human beings who are sacrificing to do this. That empathy aspect. We deal with very arrogant health officials. Yeah, some of us have even been blacklisted from even just setting foot at MOH, which is a public facility, and access to information is a right to everyone in this country, you know. However, the last time I was at MOH, 2 women entered, patients from Kenyatta National Hospital, and the first thing when they entered the boardroom, they told journalists, "You people are here taking tea and mandazi while we are suffering in hospitals." I was like, God, I love this. They were so strong.
That wasn't orchestrated. You know, when I saw that video, I thought to myself,
imagine. In fact, the thing was, they entered just after I had been asking the health CS and the PSS questions about the escrow accounts, about the shift, about everything around it. And I remember every time I shot a question, their response was no comment, no comment, no comment. But now what that did, it put the patient because no one else remembers what the CS called us there for that day. All we remember is patient stormed. But now the arrogance part was, I saw some officials wanting to drag women in front of TV cameras out of that place. I told them, look, guys, even if it's a free crisis communications class, you're only worsening the situation. We don't have that empathy to listen to people. We hear, but we don't listen. That is the first problem. Second problem is we have a communication issue. Even the people tasked to peddle shift, they don't understand it. They don't understand. It took me sitting down for 5 hours with the people building the IHTS system to understand the components. And the first thing Dr. Job Nyamero pointed out to me at Safaricom was that as per the agreement, they had agreed that they build the system for 2 years. Would you explain to me why after 3 months after signing that agreement, the government goes on and tells them we need to launch this thing when they've only finished 5 out of 17 components of the internal aspects of that system? That was the first red class. Number 2, they were supposed to roll it out for 10 years. They've ended up hurrying people there. What was the rush for? I mean, NHIF had issues, but it was working well for us. What was this big issue with that? Now, the bigger problem now with the USAID, we have issues. You realize we are in so much problems to a point. In this country, at the moment as we speak, we cannot have safe sex without USAID being involved. Condoms are not there. Last week, Dr. Deborah was saying that they only have 1.6 million pieces in stock. They've ordered for 93 million. Now, I was speaking to the Sex Workers and Bar Owners Association chair. She was telling me that in a single day in Nairobi, they distribute 100,000 pieces of condom.
Wow.
That means in 16 days,
We're
them
over.
alone can consume the entire. Number 2, they consume it alongside PrEP. When I asked the guys from Meds where the preps are, they told me, as per the new instructions, anything that is family planning related-ish, we are not going to touch it. So that tells you, how many years have we had? Since 2019, I think we've been talking about starting a condom manufacturing plant.
Did we go and did we cut the ribbon?
We cut a ribbon. We did all those things, but nothing has ever picked up. So number 4, it is also about being intentional. I've been at Apollo in India and I meet Kenyan MPs and I ask them, Mheshimiwa, you told us SHA is working. Why are you here? What are you doing here? It's like I'm the one who is part of underfunding those things. I cannot trust the Kenyan healthcare system, and he'll probably tell you that and go about his way and do his things. and go seek his medical cover. But now you see us Kenyans who cannot afford that luxury are the ones left with our bad system, with frustrated doctors. As we speak right now, interns are in the streets just for asking for internship. Like, how bad does it get to be that you deny people internship? And me, I will blame a number of people. As much as we keep on saying we'll fire the health CS, we changed to one last time, but the issues still remain. Remember, you and I know everything happening at MOH is being micromanaged from State House. So if we don't now have a discussion about the people micromanaging the Ministry of Health, we are not solving anything. That's from where I sit, because we'll just be having garbage in, garbage out, garbage in, garbage out. I've covered health for a number of years to understand. Dr. C.S. Kagwe used to tell me, before 31st December, I always have to ensure I have stock for the first 1 year, or for the next 6-7 months. You know, basic supply chain management issues to deal. It seems no one cares. And that's where the problem is.
Are you optimistic?
Yeah, so I think even amid all these things, I think we have SI unit for a healthcare service delivery unit, Murang'a County. And Murang'a County has actually ticked all the boxes of a healthcare service delivery. At governance level, I think the governor has delegated to the right people. At Human Resources for Health, recently I went for a promotion interview. I'm hoping the HR components, they're being dealt with, as in they can interact with doctors. We hope, of course, we have a big shortage and we hope they can employ more, but that's our funds developing. The medical supplies, they keep trying. Of course, a lot of people are buying because of lack of money. But healthcare financing, I think there's Kangata Care also to try to take care of the vulnerable, but also they are trying to get FIF, facility improvement back for to the people. But more important, at least what I find in terms of, if you go to Murang'a County, you'll actually get good service delivery. And this is coordinated by what is called the ICT system. And you know, we are paperless in Murang'a County. And it is a system that we actually got from MOH, which is free. So other counties can actually borrow the HMS system. And
plus the dialysis trucks. I love the dialysis. They just move around and sort out patients.
So I think we have a good
there are good examples. Sounds like it's goodwill. People are willing to listen. And it's just allowing people to also work, you know. There's a lot to cover. There's a lot. Final words, Leon?
Just before I forget, we have policemen who we send to Haiti. They currently don't have a cover. Teachers don't have a cover. Remember, SHA was supposed to get from this pot to sort out Akina TAC, so that they sort out Minet to sort out the cover. So as much as they will be wanting to take police out to slow down Mandamano, police should also remember that they don't have a cover as much as they are taking part in those Mandamanos or whatever. Just saying.
There's a lot.
But basically, we need to have a conversation with ourselves, because when the healthcare system does not function, nothing else will. People cannot function in the Ministry of Sports and play football for Harambee Stars when they are unwell. The Ministry of Labor nothing else will work without a healthy workforce. And that's why we need to have
just
an honest conversation. We need people to stop being so selfish in this country and self-centered, and understand that doctors are human beings, health workers are human beings with families who deserve to be fairly remunerated. We cannot be paying CHPs 2,000 shillings and now they're inheriting the work the people who are working for USAID were doing before they were laid off. They're the ones with that burden, and we want to achieve UHC. How are we going to do it when I know of a lady called Rita? Her work is to find HIV defaulters in Kibra every single day, knock on doors of strangers just to remind them to take medication, to go to clinic, and teach everyone else about HIV awareness and all that. She gets paid 3,000 shillings. So she told me she uses that 3,000 shillings to buy airtime to reach out to more people. That is the sad reality of our healthcare system. So if you see today's Healthy Nation, we highlighted a discordant couple whereby the gentleman was born with HIV. The lady is HIV negative, but they told me about how U+U is working. But one thing the lady told me is that whenever things will get tough, like in any relationship, she would run to that healthcare worker who used to be her good friend at the Amref clinic that was shut down because of that order. She would run there, and this person would even talk to the husband. So these communities have lost more than even access to medication. They have lost real human beings who they had cultivated relationships with, which are very integral for our healthcare system, because these health workers were playing the role of psychologists, they were playing the role of big sister, best friend, and all those things combined. So if we are to put our house in order in terms of healthcare, we first need to get politicians, MOH people to stop being on this high horse. It helps no one. At the end of the day, all of us belong to this country, and we need to have a conversation so that everyone gets a fair deal.
I couldn't have said it better, Kigondo.
Yeah, so I think most important, let's not mix arguments. Let's not lump everything. Let's, so to speak, throw the baby away with the bathwater. Is the SHA boss the problem? No. Dr. Abdi is doing a very good job. Is the presidential advisor on health the problem? No. He's actually doing his work. He has advised on policy. What is the problem? The problem is Treasury. They have refused to give us money. Parliament.
We need to have a conversation with Treasury.
So I think at the end of the day, financing of healthcare solves our problem. People would not be
financing and governance.
Yeah, people would not be complaining if health was financed. They're able to go to the hospital, get treated, go out without financial distress.
You need to find us the governor of Murang'a to give us optimistic stories, and a few other people. Even Treasury at this rate, we might need to have a conversation.
Yes.
Leon, I liked what you said. We need to have an open and honest conversation, and we'll keep having that on the One Health Lens podcast. We'll see you next time.